Thank you for coming.
Thanks, Rob. Good afternoon. I'm Dr. Gordon Caldwell. I'm a consultant physician from Worthing Hospital on the South Coast, and I've been qualified since 1980. At the beginning of the talk about cardiopulmonary resuscitation, I want to point out that if I develop an acute coronary syndrome during this talk, and that's complicated by an episode of ventricular fibrillation, I want you to resuscitate me. Because if that happens to me during this talk, and you resuscitate me, and you've been trained properly by Rob, there's a 50% chance that I'll go on living for a good long time afterwards with good cerebral function. So CPR, used in the right context, is very effective. The reason it's the right context for me is that although I'm 60 years old, I'm fit and healthy. On a fitness scale, I'd score about 2, which means that I'm fairly active, and once a year I do something very active, which is go skiing. And if you're in good health and good state of physical body, cardiopulmonary resuscitation in the context of a cardiac arrest is a potentially successful procedure. The other thing I'd say is that if you find your mind drifting off and you wish you're on Twitter or doing your emails or hadn't come to this meeting whilst I'm talking, can you think about what you would like the end of your life to be like? Picture in your mind a picture of the scene that you would like to exist when you come to the end of your life. Now, I won't go into the details, but I know that the picture that I have is being at home, on the bed, with my family around about me, with them coming and going, still doing ordinary family things around about me, and when the time comes for me to die, I'd like to stop breathing and pass away and die comfortably, calmly, loved by my family, clean, and a respectful, dignified death. So if your mind's drifting off, go back to that. I want to talk about the limits that can be achieved with full cardiopulmonary resuscitation and the confusion we're currently in around do not attempt full cardiopulmonary resuscitation. I'm really pleased that Kate's here because we've shared so many ideas and thoughts and refined our thinking together over Twitter about these thoughts, about these issues. And I think it is very important to use the right words. I didn't hear the talk just before lunch. People go to the bedside and say, I want to talk to you about resus. It's not resus, it is full cardiopulmonary resuscitation. It means a very specific intervention, and it doesn't mean all the other forms of resuscitation that might be used, like antibiotics, dialysis, lots of advanced treatments, can still happen for somebody who is do not attempt cardiopulmonary resuscitation. So I'm not talking for nurses here or paramedics about what happens if a patient's false teeth fall down the upper airway, or whilst they're eating their dinner they choke and a pickled onion goes into the upper airway. In my opinion, an upper airways obstruction should always be removed. It's such an uncomfortable and horrible thing to happen, to have your upper airway obstructed. It should be removed. So I'd like actually to move away from full cardiopulmonary resuscitation to full cardiac resuscitation. So I'm not talking about medical emergency teams, and I think you have a very good medical emergency team and an escalation system in this hospital. Somebody's news score deteriorates. The medical emergency team come along to the patient before the disaster has happened or whilst it's happening to intervene and try and work out what's happening. In our hospital, when we instituted an escalation system like that, the biggest outcome of the escalation system was recognizing how ill and frail our patients were and confronting the fact that they were probably dying, and part of that was then the issuing of the DNA CPR order. So I'm talking about finding a patient in a death-like collapse, no pulse, unconscious, breathing stopping, and whether it's always ethically right to start chest compressions, establish ventilation, and use advanced cardiac restart procedures. In a cardiac arrest, the heart is the first vital organ to stop. So this is an ECG of a patient who develops ventricular fibrillation at this point here. And by this point, the patient is unconscious usually, just within a second or two. That's a cardiac arrest. The cardiac output immediately stops. Within a few seconds, the patient becomes pulseless and unconscious. If cardiac output can be restored by defibrillation, then the patient's health can be restored to the level it was 1 second before the heart stopped beating. So if the patient had metastatic breast cancer 1 second before the heart stopped beating, and you somehow managed to get the heart back into sinus rhythm, the patient would still have metastatic breast cancer and be just about to die. We know that in this situation, which most commonly occurs during a myocardial infarction, that if we can intervene, start chest compressions, establish the airway, and defibrillate the heart, there's a 50% chance the person might survive to discharge from hospital. That's in the context of an acute myocardial infarction complicated by ventricular fibrillation. Very specific medical conditions. It's life-saving under those circumstances. If there's any delay in starting the basic life support of ventilation and chest compressions, brain damage is inevitable after 2 minutes. It probably starts earlier than that, the older you are. So unfortunately, by 20 years' time when I'm 80, it's probably not 2 minutes before brain damage starts, it'll be 1 minute before brain damage starts. So brain damage follows very quickly unless there's effective resuscitation. Other organs are more resilient, but and you'll know that if patients had their heart rhythm restored after a cardiac arrest and is taken to intensive care, commonly get shocked lung, kidney failure, circulatory failure. A few patients, I was talking to a meeting about dysrhythmias this morning, a few patients, we know that this sort of dysrhythmia is likely to happen. People with cardiomyopathy, people who've got advanced cardiac failure, are much more likely to develop ventricular fibrillation as a primary problem, and those people are fitted with implanted cardiac defibrillators. And they're very successful. I can think of two people, one person I know who's no longer alive, who died when she was about 25, who could probably still be alive now if she'd had an implanted cardiac defibrillator. And another person I know who at about the age of 30 had one put in and is still alive and working as a nurse. So they can be very, very successful. But if we're all going to die of cardiac arrest, then we should all have cardiac defibrillators implanted. But of course, we're not all going to die of cardiac arrest. We're all going to die, for sure. So I coined the phrase ordinary dying. So in ordinary dying, the vital organs fail and the heart stops last. The whole of our physiology is designed to keep the heart beating. So when all the physiology has failed, the heart stops and the patient has died. And you all know the vital organs. You talk to your children about them. The brain, the lungs, the heart, the gut, the kidney, the liver, and so on. What doctors always seem to forget is the largest organ in the body, which is the skin. So if you have a pressure sore, you have skin failure, which is failure in the biggest organ in the body. So all the metabolic processes are designed to keep the heart beating, and if they all fail, which inevitably happens when somebody is dying, you see an ECG that's recording like this. I can remember seeing recordings like that at the end of many failed cardiac resuscitation attempts. But if you work in intensive care and the decision is taken to stop ventilating somebody, knowing they're brain dead, and you leave the ECG monitor on, that's what you see going on sometimes 30, 45 minutes after the patient has technically died. So some electrical activity of the heart can continue for a long time after death. So do not attempt cardiopulmonary resuscitation orders, therefore, in the context of ordinary dying, do not use full CPR treatment for cardiac arrest when the person is dying from ordinary vital organs failure dying. And I know in our intensive care unit we have some patients who are getting the most intensive treatment the hospital can give them, but are also listed as do not attempt cardiopulmonary resuscitation because if the situation goes downhill, it's all organs failing and the patient is dying. So this goes right to the core of what is ethical medical practice. It's a book by Stephen Miles, an ethicist in America, The Hippocratic Oath and the Ethics of Medicine. And he really reminds us that clinical treatments, medical treatments, approved treatments we train for years as doctors to be able to do, and you as nurses to be able to do, have got specific indications, absolute and relative contraindications, and are more likely to work than cause harm. Of those three, the last one is the one where we get into more difficulty. For example, if a patient is told they need a coronary artery bypass graft, they may be told their chance of immediate mortality is 1%, 2%, maybe even 5%. And then there's a difficult decision for the person to make. Am I willing to risk that I'm the lucky 95% who get through, or am I willing, for the sake of 5% who'll die? And that area would fall clearly into ethical practice, particularly if it's well discussed with the patients and relatives. So to illustrate the point, I'll take you right away from the heart to King Edward VII. So when Queen Victoria died, of course, he became King Edward VII. And 2 days before his coronation day, he had terrible pains in his abdomen, fevers, and became really unwell. And they called in all the top doctors of the day, including Lister, the surgeon who had invented sterile techniques in the operating theatre and was using chloroform as well. And they all decided that if they didn't intervene, King Edward VII would die, and he wouldn't be crowned king, and that'd be a bit of a problem. So they recommended he had his appendix taken out, he suffered with appendicitis, and he was able to be crowned as king, and was king for a few years. So that's a life-saving treatment. If he hadn't had that, we wouldn't have had King Edward VII. It's a clearly life-saving treatment. The indication is suppurative appendicitis. The contraindications are not having suppurative appendicitis, and there may be lots of other contraindications as well. So it's an ethical treatment. Full cardiopulmonary or full cardiac resuscitation is an ethical life-saving treatment for the specific indication of a cardiac arrest. Heart stops first, cardiac arrest. So I'd argue that a patient who's doing full cardiopulmonary resuscitation, a person who's dying of multiple health conditions, but not of a heart stops first cardiac arrest, is as illogical as doing an appendicectomy. So somebody might say, you're withholding a life-saving treatment from this person dying of metastatic breast cancer. Why don't you do an appendicectomy? Because an appendicectomy is a life-saving treatment. Because that is not clinical practice, it's not scientific medicine, it's not the way that society views medical practice, I believe. Certainly not the way that the medical profession view medical practice. So this could all be very theoretical, but I do know something about cardiopulmonary resuscitation. And Ken and I have both got huge respect for Douglas Chamberlain. If it wasn't for Douglas Chamberlain, you wouldn't have automatic external defibrillators at Victoria Station. He is a great believer in the appropriate use of full cardiopulmonary resuscitation to save lives. He followed on all the work that was done in Seattle. When I was working for him in about 1982, he asked me to see if thumping on somebody's chest when they went into VF or BT might save their lives without the need for a defibrillator. So I collected information on a large number of cardiopulmonary resuscitations in Sussex County Hospital over about an 18-month period, and spent hours going through tapes and trying to identify what had gone on with them. Now, in this study, there were 68 cases of ventricular tachycardia, 248 cases of ventricular fibrillation, and 1 in 20 survived to discharge. That meant they left the hospital. Some of them would leave the hospital with a lot of brain damage. So the success rate, in that study, was 1 in 20. And that was a mixture of out-of-hospital cardiac arrest, in-hospital cardiac arrest, coronary care unit, resuscitation unit. Which of course means that there were 95% who died having had full cardiopulmonary resuscitation. And the worst memories I have from that period of time were cardiac resuscitations on general medical wards. So there's a ward at Sussex County Hospital called Chichester Ward, which faces out towards the west. And in the top northeast corner, about 2 beds from the window, I attended a cardiac arrest on a frail, elderly old lady in the middle of the night. And in those days, we'd go through the whole process, central lines, defibrillation, lots of different medications into the central line. You'd always finish up by putting a needle into the pericardium in case they had a hemopericardium, and then put intracardiac adrenaline into the left ventricle. By the end of that, this poor, frail old lady had vomited, she'd had diarrhea, she was naked, she had lines in all over her. When I was doing the CPR, I could feel the ribs cracking underneath my hands. I could feel the sternum cracking underneath my hands. As the resuscitation went on, I could feel the skin and the tissues becoming soggy. And it's only in retrospect I think, what was I doing? I'd come into medicine to cure people where they could be cured, and to comfort them when they couldn't be comforted, when they couldn't be cured, and to secure a calm end of life for them. And somehow this was being accepted as the ordinary thing that we ought to do to people who are in frail health. So I can still see clear pictures of that, and I believe this sort of thing still happens from the reactions from my junior doctors when they come back from cardiac resuscitation attendance. So just to remind you that it is a good treatment, and it's good treatment when it's used for the right reason. Best circumstance for resuscitation from cardiac arrest is ventricular fibrillation, this one, or ventricular tachycardia during acute myocardial infarction. That's probably not the best. The best situation is if you've got a primary cardiac dysrhythmia which causes ventricular fibrillation, and you've got an intracardiac defibrillator. So sometimes primary VF or VT. Cardiopulmonary resuscitation, when it started, the instructions, as I understand, are still that the patient's meant to have no pulse. They don't respond when you say Mrs. Smith, so they're unconscious, and their breathing is usually stopping. Of course, it's good. It can be very good in the street. If you see somebody walking down the street who then clutches their chest, falls to the floor, and is pulseless, first you know that they're fit enough to be out in the street and walking down the street. That is, in medical terms, a lot of fitness. If you can walk up one flight of stairs, you're as medically fit as somebody who does marathons, as far as I can see, in terms of anaesthetics and outcomes and such like. So you pre-select people who are not bedbound, who are not hugely clinically frail, by the fact that they're in the street already. Of course, that's changed a lot in the last 20 years, because anybody can get out in an electric buggy, and you may have people who are extremely clinically frail out in the street, but the layperson can't decide that, and if you see somebody collapse in the street and they're truly pulseless and unconscious, I think it is right to start that, dial 999, and hope somebody brings the AED very swiftly. So, cardiopulmonary resuscitation, cardiac arrest, the heart stopped first, the other vital organs rapidly follow on afterwards, 2 minutes to protect the brain. I can be on my general medical ward for 30 to 40 minutes without seeing a nurse. That means patients can be on the ward for 30 to 40 minutes without seeing a nurse. So if they collapse, we've got 30 or 40 minutes of brain damage before somebody recognises it. But of course the person in the next bed might do something about it. But we've got very poor systems for monitoring patients in hospital. Isn't it odd? You've got a smartphone, you can measure your fitness, you know how many heart steps you take, you know your heart's beating when you're out in the street, but we haven't mastered that in hospital, even to know that people's hearts are still beating. If we had some system that worked off the smartphone, we could probably see the news score and everything deteriorating in advance, call the MET team, and make more sensible decisions. So the person who's having out-of-hospital cardiac arrest is generally far fitter than the patients I see on our general medical wards. And in all the studies that you read about outcomes of cardiac arrest, whether it's from Seattle, whether it's mine from Brighton, I have never seen anybody try to work out, by, say, following up with a post-mortem study, how many people, that proportion of those people, do you really think died of a cardiac arrest as opposed to bronchopneumonia, disseminated cancer, sepsis, kidney failure, failure to eat and drink? I suspect that the proportion of people who die of a true cardiac arrest is probably somewhere around about 3 or 4% of the population at the most. So it's illogical then to try a specific treatment to the other 95%, in case there are 2 or 3% who might actually be dying of cardiac arrest. But let's assume that you're dealing with a person who's maybe 80 years old, a bit underweight, breast cancer, kidney failure, some kidney failure, type 2 diabetes, a bit of a pressure ulcer, who you've been chatting to about betting at Ascot, having a nice time, have a few jokes with them whilst they've been in the ward. If that person actually has a coronary thrombosis, complicated by ventricular fibrillation, which is the indication for a cardiac resuscitation procedure, what are the chances of recovery? Extremely low. They have got so many contraindications that you cannot get the heart going again. These are the situations where you've been on a cardiac arrest, 5 minutes in, somebody pulls out the notes, reads them to the medical registrar or the consultant anaesthetist, who immediately says stop. And I'd argue that if 5 minutes in you immediately say stop, that's an indication you should have thought things through beforehand and never have started. Benjamin Franklin said, failing to prepare is preparing to fail. So we should be prepared for that situation, particularly as this represents, I would say 80% of the patients I look after now as a general physician, that they've got multiple comorbidities, we call it. And there's evidence on this. A study from Scotland where they looked at the outcomes for 10,743 inpatients in Scottish hospitals on the 31st of March 2010. That's everybody who was in hospital. So if you've been in to have a thyroidectomy, you just kept in overnight, you're included. And if you've been in for 6 weeks with dementia and poor nutrition, you were included. And at the end of a year, 28% of those patients had died. So if you come into hospital, you should start to think about your own mortality. Particularly if you're old, and particularly if you've got multiple comorbidities, but by the time you're 85, the mortality in the next year from ordinary dying is around about 50%. So we know that the patients that we're thinking of as clinically frail already have an extremely poor prognosis. So ordinary dying is progressive failure and weakness of many vital organs. Functional decline is particularly important, so decreasing mobility. Somebody who's spending more than half their life in a chair or in bed has importantly impaired functional decline. That progresses, all systems down, and finally the heart stops. So it's like HAL in 2001: A Space Odyssey. The computer progressively fails until it shuts down and says all systems down and closes down and the computer's gone. In our body, all these systems shut down until you're left with the person dying. So of course this begs the question of how do you recognise clinical frailty? And I'd say that I've used a scale called a Frailty scale, which I've renamed a Fitness Frailty scale because it sounds better than that, and you're talking about somebody's fitness to them. So are you a marathon runner, fitness 1? Are you somebody who likes to get out on a mountain bike a few times a month and goes skiing once a year, fitness level 2? Are you somebody who just walks around and doesn't do anything else beyond that, fitness level 3, and it goes right down to 8 and 9? But when you think about fitness and frailty, I'm thinking a very similar way to thinking about happiness and unhappiness. That the more you think about it and try to define it, the less you get to the point. But you can recognize it and you can see it. Now there's a lot of information that goes into an expert opinion about frailty. And I suspect that if you took a group of 100 geriatricians and tried to get them to decide whether a group of patients were frail or not frail, they'd probably agree on the vast majority between frailty and not frail, with a small group in the middle, maybe 10% in the middle. The way that I go about it is I write down a list of the diagnoses and comorbidities. So this patient has come in with left lower lobe pneumonia, had a left upper lobe resection 6 months ago for bronchial cancer, which has recurred. They've got chronic kidney disease stage 5, type 2 diabetes, a pressure sore, and they don't walk further than 3 yards. So that's the problems. They had recurrent admissions? The immobility is really important. Nurse opinion, excellent, really important term to the nurses, because nurses are far better, I think, at doctors first at knowing that somebody's dying, but unfortunately far less good at telling everybody else that they think that somebody's dying. So asking the nurse, and usually if you ask the nurse, when it gets to the stage, I say, do you think this person's frail? The nurse will say, yes, of course they're frail. I don't know what you're doing so many things for this patient when we should be addressing a different issue, which is end of life. Falls risk and falls, nutritional risk, pressure sore risk, all these things that as nurses you're really expert at assessing and doctors ignore all the time, turn out to be hugely important for decisions about frailty. So I sometimes have brought with me, I haven't set them up, my Jenga bricks of frailty, and on each brick is a name of a medical condition or a problem. And the truth is that the older we get, the bricks are taken out from the bottom of the pile. So if you're young and you develop a testicular cancer, it's just one little brick off the top. Whereas if you're old and frail and you develop pneumonia, it's a brick right in the middle at the bottom, and as that's pulled out, maybe the whole tower falls over. So the list of diagnoses, comorbidities, especially from the medical point of view, cardiac failure. So somebody who can't walk to the kitchen and make a cup of tea because they got breathless has got severe cardiac failure. Not a little bit of cardiac failure, severe cardiac failure. Somebody with chronic obstructive pulmonary disease with an oxygen saturation of 92%, sitting there playing cards, has got severe damage to their lungs. Your oxygen saturation should be 98, 99, 100%. 92 means you've got really extensive damage to your lungs. If you've got chronic kidney disease stage 4, your kidneys are really badly functioning. Things that we just think of, that's ordinary. Oh, another patient with an oxygen saturation of 90 with cardiac failure and an EGFR of 15, let's move on to the next patient. It's so ordinary. And of course, metastatic cancer and immobility, which I said already, doctors tend to ignore. So the ethics of DNA CPR is a recognition that I think after those events I had to describe on Chichester ward, we introduced at that stage do not attempt resuscitation, TLC, for tender loving care. And then that became something very complicated with the DNA CPR form. TLC became the Liverpool care pathway, and somewhere in the midst of all that we got into a real mess. So the reason behind a doctor issuing a do not attempt cardiopulmonary resuscitation, or certainly in our team the reason behind it, is a recognition of clinical frailty and a desire to save the patient an undignified and brutal dying. CPR in frailty is futile and could be assault. Now, I know we've got a lawyer here, and she could say to me, it's self-predicting. You've said this person's coming to the end of their life, therefore you're not going to do something which would save their life, therefore you died and you've proven your point. But I hope you've got more trust in the medical profession than that, more recognition of our expertise. And I think that there is a way of recognizing people where cardiopulmonary resuscitation is futile and could actually be assault. If you think about it, you've got a whole lifetime to decide about whether you'd like somebody to press on your chest when you die. And we as doctors have got several, sometimes years with our patients to say, would you like somebody to press on your chest when you die? So why don't we take informed consent? If we took informed consent and said, we will do this only if we have a strong belief that you're having a cardiac arrest complicated by a dysrhythmia and you don't have the contraindications of multiple comorbidities, then it would only be a tiny number of people that we actually ended up doing it in. And those people could wear a 4 CPR wristband if they wanted to. So how did we get into this mess? And it is a mess. I was telling Kate on Twitter last week, a man I spent 40 minutes with, an intelligent man, aortic valve disease that wasn't suitable for cardiac surgery, chronic obstructive pulmonary disease, increasing mobility, who had come in with a urinary tract infection. And he was elderly, so I thought it was reasonable to have a discussion about end-of-life care. I spent 40 minutes with him on 2 days, at the end of which he said, I don't understand what you're saying, you're the doctor, you make the decision. And yesterday I had another 40-minute conversation with a man who both of his wives had died of pulmonary embolism by the sounds of it, talking over a very similar area. A man very elderly who's still working as an accountant, who couldn't understand why I was having this conversation with him, when I just told him that he'd had a urinary tract infection, he's going to be going home in 4 days. And I was having to have this conversation because, as a consultant, I know there's maybe 1 chance in 20 in those 4 days some intervening disaster will happen. He might deteriorate, which I'm not anticipating, and I don't want him to suffer the indignity of dying with cardiopulmonary resuscitation. So it can be really confusing for our patients, so that's a mess. Is the doctor telling me I'm getting better, or is he telling me I'm dying? And there's been a huge demographic change in my career. Talking about those times in Chichester, it seemed easy. The patients were dying, and we shouldn't be doing something like this to them. Now we've got a huge cohort of people over 80, a lot with long-term medical conditions, whose health is so frail they couldn't withstand a cardiopulmonary resuscitation, even if they needed it. These are the people who, if they went to a cardiac surgeon and said, could you do open heart surgery on me as an emergency procedure, not as an elective procedure, if my heart valves fall to pieces, they'd say, no way, because we wouldn't ever get you through this. And cardiopulmonary resuscitation, because we're all trained to do it, we think, well, we are trained, and if you do it really quickly and really well, of course you save a life in the high street and you save a life in the emergency department. But that's very different from a mobile, frail patients lying in our beds in our general medical wards. So again, I was really sorry I missed the discussion about that you were having just before lunch about how do you talk about these things. And we want to talk with the patient, or we talk with the relatives, and they say, do everything, doc. So pretty much the guy who had the aortic valve said to me, you decide what you want to do everything, doc, that you think, well, he didn't say do everything you think's right, just do everything. In medical practice, do everything is restricted to ethical acts. If you ever saw Monty Python's Meaning of Life, the live donor team come in and take organs out of living people with chainsaws. Well, technically you could do it, but it's not an ethical act. So what we do is restricted to ethical acts. So when the patient or a relative says, do everything, doctor, in their minds, although they don't say it, is do everything that you know as a doctor is wise, kind, and more likely to work than cause suffering. Because that's what doctors do, that's what nurses do. They don't think you need to say it. And how do I know that that's what they mean? Because when the patient has died the next day, they come in and say, but he didn't suffer, did he, doctor? Which means they said, do everything that doesn't cause suffering. And when they've said, do everything, doctor, and in my career I've seen it happen, that person then has cardiopulmonary resuscitation as they die, and the relative comes in and says, he didn't suffer, did he, doctor? We lie. We say, no, he didn't suffer. But we know that he did. And honesty is a core value in medicine. So we make ourselves do something which then consequently means that we lie to the relatives. So the request was, do everything that does not cause suffering, doctor, and is likely to work. And the truth is that for most of our patients on our general medical wards in hospitals in the UK now, and on your intensive care units, we've been doing everything already, but it didn't work. And when we do everything already and it doesn't work and all the vital organs fail, the heart's the last organ to stop and the person has died. And whatever we do, in the terms of the nursery rhyme, we can't put Humpty Dumpty back together again. So the power of words. I was brought up reading George Orwell, and the message from George Orwell is that words really matter, definitions really matter, explaining what we're talking about really matters, and being straightforward really matters. Because if you're not, you can end up with things being the other way around. So people think that the DNA CPR is doctors being cruel to a patient. So you're not for full cardiopulmonary resuscitation treatment. Sounds like we're denying you a treatment that will work. So as soon as the doctor says resus, the patient thinks, oh, that's something that's going to work. Why would I turn down something that's going to work? So our choice of words is poor. And if we don't restrict it to cardiopulmonary resuscitation, or don't even abbreviate it to CPR, I'm afraid I have abbreviated it in this talk on the slides, say cardiopulmonary resuscitation. And this gives the patient a chance to say, well, what is cardiopulmonary resuscitation? Oh, it's something used if you have a myocardial infarction, and so on. It's complex. And this is the bit I think we're really struggling with now. You're well enough to get better, but not well enough to come back from even a true cardiac arrest, and you certainly won't come back from inappropriate cardiopulmonary resuscitation. Some people believe that DNA CPR means no active treatment. That's wrong. So I was listening to our nurses on the morning handover in the last few weeks, and we're sharing a handover now, so they'd read down and say, this is Mrs. Smith with her pneumonia, a bronchial cancer, chronic kidney disease. Actually, they wouldn't say that. She'd say, this is Mrs. Smith, she's DNA CPR, she's got pneumonia. So I've changed what we put on our handover to, this patient is full ward level care, but happens to be DNA CPR. At least put into context that what we're restricting is cardiopulmonary resuscitation. That person can still have antibiotics, might still go to the intensive care unit for monitoring of fluid balance, might still have a major surgery. And in America, there's published series of people who've had major surgery who have elected to be not for cardiopulmonary resuscitation. So it means there's one thing you're not going to have. So if there's somebody in the population who never wanted to have an appendectomy and wrote, I do not ever want an appendectomy, we'd have to respect that. But most people want to have treatments that will work. And we could do an appendectomy in somebody who's maybe got a prognosis of 6 months from another cancer, because that we know they could survive through the appendectomy. So there's lots of treatments you can have, even if you do not attempt cardiopulmonary resuscitation. So we need to reframe our thinking as doctors and nurses. This is our red form. I'm sure Kate's got lots of examples of red forms. But it says, do not attempt cardiopulmonary resuscitation, adults aged 16 and over. In the event of a cardiac or respiratory arrest, do not attempt cardiopulmonary resuscitation. All other appropriate treatment and care will be provided. And so it's there, line 4. All other appropriate treatment and care will be provided. Now, as nurses, I've heard of nurses taking the slow walk to the cardiac arrest phone. Because I know in our hospital that a patient with rigor mortis had cardiopulmonary resuscitation, because my junior doctors came back and told me, and they were shocked and disgusted. So sometimes I've heard that nurses recognise the patient's dying, knows that there isn't a DNA CPR around, so takes a slow walk to the phone. I think you can respect your own professionalism here, because it says, in the event of a cardiac, I'd like to take the respiratory out, in the event of a cardiac arrest, do not attempt CPR. Well, the patient's not having a cardiac arrest, they're dying. So of course you don't need to try CPR. So even this form allows you to say this person is dying, but not of a cardiac arrest. Another reminder about the power of words. I don't think doctors should talk about quality of life at all. We're scientists. We should talk about the quantity of life. So a cardiologist can tell you that the quantity of somebody's cardiac function is an ejection fraction of 10%. Which is really, really bad cardiac failure. A respiratory physician can tell you that somebody's respiratory function is 50% of normal. Really, really bad respiratory failure. The kidney doctor can be even more precise about how bad the kidneys are. Say, pressure sore is failure of the vital organ of the skin. So we can at least count the number of organs that are seriously damaged to get some idea of the quantity of life. And somebody with a tiny quantity of life can have a very good quality of life. So the diving bell and the butterfly, the guy who could only communicate by winking his eye, he communicated a whole book whilst he was like that, and he was enjoying some form of life, and he would have said that he had a quality of life, whereas we might have thought it was very poor. But his quantity of life was very poor, and that was proven because he died. So I think we should talk about quantity of life. So I don't think a doctor has much expertise to judge quality of life, and how many vital organs are affected, and how immobile and dependent has the person become. But immobility and dependency severely restricts our abilities to restore good bodily function. So I want us to move away from this. We concentrate almost entirely on the DNA CPR now. I can walk to the end of the bed and see in a blink that somebody should not be for CPR. And of course I want the red form filled because then I can relax and know the person's not going to get CPR. And so then the conversation between the junior doctor or me and the patient is immediate. You've got pneumonia, we're not your DNA CPR, we'll phone up your relatives and tell you. We want all that done and dusted. Actually what we're talking about is what does the person, which I think you were talking about before lunch, how does the person want to come to the end of their life? What do they want to be happening? How much medical interference and meddlesomeness do they want? So if we start to think about, I want a peaceful death, which is what I asked you to do at the beginning of this talk, think about how you would like your death to be. And if 100 of you in the room, you all have different ideas, but I'll bet that they aren't having cardiopulmonary resuscitation done to you on a general medical ward in an NHS hospital. So recognise clinical frailty, think about, I want a peaceful death, think about this approach. What does the person want? The frail elderly person with multiple comorbidities. Once we've recognised it, we could reduce polypharmacy, we could stop simvastatin, aspirin, clopidogrel, alendronic acid, all sorts of things that are contributing nothing to their well-being. Make plans for the time before and including the end of life, and focusing on the DNA CPR restricts our vision. And I would say cardiopulmonary resuscitation is possibly, may well be an unethical treatment in clinical frailty because it doesn't meet the criteria and has got many of the contraindications to the degree that the suffering to the person, to the relatives, and to all the people who have to do this procedure outweighs any risk, any chance of benefit. So how could we try to approach this with our patients and relatives? Putting it into the context of I want a peaceful death, I could say to my patient, you call me doctor, I recommend you request peaceful dying for the future end of your life. Make a statement, you want peaceful dying at the end of your life. Tell us the things you don't want us to do. Or for what I asked you to do, from your mind's eye, paint me a picture of your future ideal dying scene. Write a poem, write a book, paint it, put it in a text, whatever. Tell somebody about it, what it is. It will be emotional. When I did this, I wrote it down on that form you've got there, Rob, and I was crying for half an hour whilst I wrote it. So it will be emotional. And nobody pictures cardiopulmonary resuscitation. Well, I haven't met anybody who says, I want to die having cardiopulmonary resuscitation. So somebody might paint a beautiful picture of their family and how they want to be, and how they want to be calm, and they don't want to trip, and they want to be warm and clean, and the grandchildren playing on their knees, and then they just take the last breath and die. And then we have to come along and say, are you absolutely sure you don't want cardiopulmonary resuscitation? It's like saying to a vegetarian, what do you want for your ideal meal? I want a nice vegetarian roast. What, you mean you don't want steak tartare? Are you absolutely sure? No. The other context might be to think of gentle care for the clinically frail. So gentle care, that sounds the sort of thing I'd like to be doing as a doctor. My clinically frail patients, being gentle with them, not forcing them into lots of treatments that NICE tell me I've got to deliver, or that somebody else tells me I have to do, or particularly that I've got to do cardiopulmonary resuscitation unless I've had the conversation with the patient and with relatives, and the person seems to be dying. So gentle care for the clinically frail. So widen our thinking from the narrow, controversial, and gentle care to DNA CPR, do not attempt cardiopulmonary resuscitation, to gentle care in the seventh age of man. So Shakespeare wrote about second childishness, mere oblivion, songs without. Sans teeth, sans eyes, sans taste, sans everything. And I'd say sans cardiopulmonary resuscitation. So once there's the reminder of the Jenga bricks of clinical frailty, the ways that it is actually fairly easy in the majority of people to identify that they're in frail clinical health, and we should be discussing together then what are their hopes for the remaining time they have alive, and when it comes to dying, what are their hopes and aspirations around dying, and make this DNA CPR a small part of it. But because of the situation we're in this current cultural environment, I think the person's almost got to then wear a DNA CPR wristband. So I heard of a patient at Sussex County, I think it was, who had disseminated cancer. Somebody had had the conversation with him. He said he definitely didn't want cardiopulmonary resuscitation. He knew his life was very limited. He went downstairs to have a cigarette and was smoking in the car park when he collapsed in the car park. And the paramedics happened to be going past, and they did full CPR on him, because he didn't think to take the red form with him. So if you think about it, we may need to get to the place maybe where people wear a "I want a peaceful death" bracelet, which allows people then to stand back and to help to provide a peaceful death, which is a difficult thing. Families don't know what it's like having somebody die at home. What happens when they suddenly become breathless? Probably because they've had a pulmonary embolism in the context of disseminated cancer. It's frightening, it's scary, you need people to help you. But you don't need the help of them coming to do CPR. Probably you need to help them to come and say, this is how people die sometimes. I can give some morphine, I can help. So a DNA CPR order is an act of professionally wise kindness in clinical frailty. Thank you.
As we say, Gordon has got to go, but you're quite happy for a few questions, aren't you? And I know, Gordon, you're not familiar with Gordon working in the hospital, but I would say, feel free to question him, even if you want to criticise anything, if you don't agree. This forum, we're all adults, we're all mostly healthcare professionals, so challenge each other. That's the best way to learn. You wouldn't mind that, would you?
No, of course not.
So the floor's open to you guys.
I'd be interested, particularly
Kate, obviously Masters. We haven't introduced Kate yet, but she's not a healthcare professional. She's a relative. She's Janet Tracy's daughter, and she's up next. But so, Kate, what would you like to ask Gordon?
With the form being so important, but the conversation to me is a precursor to the form being even more important. Have you got any thoughts about all those conversations you have with the patients seem to get lost in the notes? For their wishes to be on the form, so basically the questions that you put up on your slide, I mean, there is something called the Max End of Life Care form, which was devised by a clinician who was dying. And there were 3 questions, I can remember 2 of them: what's important to me, who's important to me, and I think the third was, in the event of that I'm dying, you know, how they would like to be treated. I was just wondering if you had any thoughts on that being more prominent, because it's there in red, on red form, you know, what to do, what not to do clinically, but just to sort of up the importance of what the patient wants for everybody to see, because I think when you're in hospital, you see so many doctors, it's hard to know who knows what.
First thing, I suspect a lot of the time you're incorrect in believing that the conversations happen before the form's being filled in. And a lot of the difficulties we face are because, as emergency doctors, somebody's come into the emergency room, you know they're an extremist, you've never met them before, and you've got to make a decision pretty much there and then about what levels of care you're going to do and where you're going to go. So the conversation should have happened beforehand. So that's why, as society, we need to grow up and have the conversations well before you end up in hospital. So then you're faced, the Royal College of Physicians says that the DNA CPR decision should be made at the first senior review or the consultant on the post-take ward round. Well, I find it's difficult enough to explain the primary diagnosis to the patient and how ill they are without going into the conversation about the DNA CPR. But at the same time, I know that the person is at risk of suddenly collapsing, maybe a low risk, maybe 5% risk, but it's still an important risk, suddenly collapsing, and do we then do CPR? So that actually the decision's made in the head very, very quickly. And if I would think most of the conversations in general medical wards in our country, I could be wrong, happen after the form's been filled and then you may get some documentation in the notes that the conversation's had. I went to see, we filled in the red form, I went to see Mrs. Smith, explained this to her and phoned the relatives. So the decision's been made in the wrong place at the wrong time, but at the moment that's the only place and the only time that it can be made, which is why you and I are raising this issue to try and get people to think.
But trying to make the best of that situation, do you feel there is a place for the two to be put together, so the wishes and the form to be put together, so that everybody else knows the conversation's been had, they know the extent that the patient knows about it, and they can just flip it over and see what is important. And I think more importantly as well, who's important to that person, who they want it shared with. That, I think, is pretty crucial.
I don't know if you've seen the advanced care form there, and somebody will be talking about that. I think what we're moving towards in our ward is that we're trying to identify people who are clinically frail. Then our nurses have authority to start that conversation with the patient. So if we know somebody's going to be in for 8 or 10 days, then we put sowing the seed in their mind about that. So during the time that they're in, then they might be able to fill this in, and then so that when we send the patient out, they're prepared for the next time they come into hospital. So that's a bit closing the door after the horse has bolted, but is better than what we were doing before. I think I'm getting more relaxed with the idea that somebody doesn't have a DNA CPR who I think wouldn't survive, because actually maybe the risk of the immediate deterioration is fairly low. The situation where somebody is obviously dying and I go to the end of the bed and say, get the relatives in, this person is going to die in 2 hours, that situation is actually maybe very emotional, but it's extremely straightforward in most cases, because say your relative is dying, you probably want as much time as you can with them, get there, and there's going to be no heroics when the person dies. And most people...
Ken's got a question.
Yeah. Two points I'd like to make, if I may. One is regarding the NC pod report Time to Intervene, which an appointed body of experts recognised from a 2-week snapshot of cardiac arrest in, I think it was November of 2010. They indicated that 89% of in-hospital attempts at resuscitation were considered entirely inappropriate. Secondly, the National Cardiac Arrest Audit data, the second report from that group that I sit on the steering group of, indicated that 53% of cardiac arrests that occur in hospitals happen after 1 day, 24 hours of admission. So they would argue there's sufficient time to have those very important conversations. That evidence is hard evidence, it's out.
I think the challenge we have as doctors is that we don't have the luxury of very much time, which I think for us to be able to say to our nurses, we believe this person's in clinically frail health, next time you're doing a bed bath, why don't you start the conversation, is one of the ways it can be handled. Yesterday on my ward round yesterday, it took me 40 minutes, surprisingly 40 minutes, on in the middle of the ward round, which then delayed everybody else's case, but I don't have any other time.
So we've got a couple more questions. Philippa and Robert. Rob's first, yeah.
Thank you very much. I'm really interested in the talk. I love the gender part. That really makes so much sense. Any thoughts for pre-hospital? Because I just started working in hospital, and when we arrived, you've got no time ahead at all.
No.
Any thoughts on that?
Yeah,
perhaps should be something GPs take on.
I think our general practitioners are increasingly taking this on, and increasingly people are coming in holding their red forms. Sadly, the close relationship between general practitioner and his patient has been eroded for a number of reasons. But where that relationship has been maintained, and the GP can have a conversation, I've looked after you for 30 years now, you've got prostate cancer, I would recommend that you thought about how you came to the end of your life. That, to me, feels ideal, and probably me in outpatients, I should be facing those issues as well. You've had both legs amputated, you've had a heart attack, you've had a stroke, you've got diabetes, you should be thinking now about, and I think those are the opportunities that we're missing in general practice and in our outpatient clinics. People can go through oncology clinics having palliative chemotherapy, which means it's not going to work, without any addressing the issue of dying.
So I didn't know, Richard, I didn't want to keep going. We can only get 2 more questions because you've got to go.
The same question. You answered.
Oh, you've answered it. Brilliant. Yeah. Richard, last question.
As the token GP in the room, as well as an ALS instructor, I'll take the fact. But there are occasions when you do go through all the work in the hospital to do a DNA CPR algorithm form, you do all the information, you have a good chat, and none of it comes out to us. we don't get the red DNA form coming out. It's all electronic discharge. No one ever writes on the electronic discharge a decent paragraph about the discussion. And just remember that by the time they get out to us in general practice, should they survive, 3 other brothers, a sister and a nephew have turned up, and it'd be great to know the name of who the brother or the sister was, and go from there. As you say, I mean, I used to work in Dartford, I'm now covering in Medway and Maidstone. One of the biggest problems in the hospitals is they're getting an awful lot of end-of-life care patients who can't manage at home. They then get discharged out to a care home or a dementia nursing home, and because they go to a different named GP to that area, they don't get the discharge, that's gone back to their last GP. So in all probability, they'll have died within 4 days, and they may have got the palliative care team in, but not us. And very often we have to bounce it back to the Medway consultants and say, you fill in the death certificate and everything else, because we can't. And we then have to have an awkward conversation with the relatives. So I think it's down to communication, and it's just to think, what will actually help us in a dying patient? Is it to know that they've got to have their E's and U's done every 4 weeks for the next 6 months, and you know they're not going to make it, but it'd be nice to know who you told, what they're being told, and other things like that.
No, I accept all of that. Our electronic summaries in Worthing go out electronically as the patient leaves the door, and the paramedics won't take a person out of hospital unless they've got the DNA CPR form in their hand alongside the patient. And our ward clerks also forbid us from that sort of activity. But I agree. Think about
that. They go to the nursing home or the care home, but they don't actually tell us. We get an electronic form. So it's that sort of thing. That is something that's really useful, along with telling us why you stopped the drugs. Because they'll have a plethora.
No, I'm already thinking about your point, and thinking about how we police our discharge summaries every week in my team. How we could tighten up on the information about the DNA CPR.
Well, shouldn't we be offering the service for patients? We don't have a national service for patients to actually come to who, if they want to know about how they're going to die. A lot of people are very interested in how they're going to die, but we're not promoting an optional services that people could go to start with.
I think we've got extremely good palliative care service in the Worthing area, and they get a lot of COPD patients, cardiac failure patients referred to them, as well as the traditional cancer patients. But that is a discussion when you've got an illness, so that's why Kate and I are here promoting this idea that people ought to think about it before they encounter the problems, or as soon as they start to encounter long-term health conditions, to be thinking about these issues. Thank you.
Okay, thanks, Gordon. I'll walk out with you. Just to let everyone know, we're going to just slightly rearrange the front of the room for the next break, because we're going to do the next presentation in an interview style. It's not an official break, but you've got about 4-5 minutes if you need.